Good.
You see me?
Yeah.
Nice. Welcome to our next part to show of Allium stents. My name is Neymeyer. I'm from the charity, and what we want to show today is a lot of stents and how you use stents. What we find out last time is that I speak a little very fast, and I want to show you the whole part of ureter. That's why at the end, please collect also some questions. What we want to know from you is we collect the foundation of masterclass for that kind of special parts where we want to find out your questions is what we want to show next time only for problems in ureter, in fistula cases, in ureteral stents, in prosthetic stents, and all your questions, what you have today, please collect, and then we can make at the end a summary to make a new program for you, best of it, for the next webinars. What I want to show you today is the treatment of damages of ureter and what you can do with a Allium stent. This is a typical case of our hospital. What we have also today, we have two Allium cases today. One is nearly the same like here. What you see is a terminal damage, and if you use at a terminal damage, a typically double J, it is not recommended, because with a double J you can cross the damaged part, but you can't bring the fluid totally over. You haven't any chance to cover it like you see in X-ray. What we do now is we go with the scope inside, bring the stent inside, and covering totally that part what was damaged before. You see no fluid goes out, it is strange covered, and you have a fully chance to recover that damaged part in the next 4 to 8 weeks. Interesting case, in the same way, it's a neurogenic tumor. He has a long ureter with first the surgery and the neurosurgery, do a stent inside nearby the ureter. It can't be closed, the urinoma is inside. What we do is now we go with a flexible scope inside. You see the white part here, that's a terminal damage of the ureter that is fully damaged in this part of 1.5 centimeters. And we go now inside it, see that part, and covering. Interesting is it, you can cover also a long part distance. This was a ureter on this side of 40 centimeters or 36 centimeters, that not one stent is not enough. You have a chance also in that case to double or triple also the Allium stent, because you can put it stent in stent. So you have now the chance also with this technique to use it over the fully length also if you need it about or over the ureter. Now you see it, it was inside it, or it's clear. We make for security for that case, because you haven't any chance to go straight with a rigid URS inside. You need every time a flexible. We use for security here a double J inside, all it's nice. And after 1 year, we take it out, and you see an interesting part. The part of the Allium stent inside it is not incrustated. Incrustated is only the DJ what was inside it, and the only incrustation what you will be find is nearly to the kidney pelvis, or if it looks like something inside of bladder, or it can be also at the crosses. But in that case, you have no problem, because the cover of the litinol skeleton that is not fixed inside of the ureter, so you can bring it totally out with one part, no problem. And at the end, what we do now, in that case, is recommended to do a new stent inside. We do now only 2 stents. You see it. Important is if you cover it, or if you put a stent inside to another stent, you need a covering part of 2 centimeters. Under it is not recommended. And then we put it fully on it, and the patient is normally have no problems, all looks nice, and we can use it for, in the meantime, for 3 years. We recommend it long-time stent to bring also the urine out, and the longest time what we have are 5 years, but in the mean is 3 years for covering also the strictures and so on. If you have, for example, 2 problems, like in this case, like a radiation problem in the distal ureter both sides, and also a pleural junction problem, then we recommend it for that side with a pleural junction inside it, also to use it totally 2 stents, 1 to 1. And you see it here in the distal part, it is smaller, and in the smaller part there is a stenosis. You need only 1 part. That's why we use on the right side only 1 stent later to put it inside. You see it here. One side it's covered the stenosis on this side. The stenosis is in that area. You see the wideness of the normal stent, and here it is a little smaller, and that means here are the stenosis. It's typically one for cervical cancer after radiotherapy that you have this stent. And you see it here in the picture, really exact small part where is a stenosis, and all that's okay. That patient had before every 2 weeks the changing of a typically double J, because she was not only have not only strictures, she is also a stone producer. And now the stents are inside now for 2 years without any problems, and we don't change it. I said it before, after 3 years we were looking, and our treatment or control treatment is only ultrasound. If you see an ultrasound hydronephration developing, or the hydronephration comes back, then we check it with X-ray to see also stones inside or so on. Then we change it, and the changing is really simple. Interesting is it, if you use it for kidney or pleural junction pelvis problems, then you see it here. See, if the patient is moving, it's jumping also the kidney and the abdominal inside. That's why it is recommended that the stent is not only near to the pleural junction, you have to bring it also inside of 1 centimeters inside of the kidney pelvis. So that is then recommended, otherwise you have a dislocation and is not so good. Our recommendation is that we use, in case if we have strictures and tumors, they are longer than 20 centimeters, then we use stent and stent double. And what I say recommended is 1 centimeter, not too wide inside, otherwise you have a problem that the urine comes not out. And in second case, if you have a partial or a total defect of ureter, you can bring it inside and you're covering and all it's okay, and the fluid goes through. We have 2 kinds of defects of ureter. We decide in 2 cases. One is a partial defect and the second one is a complete defect. A thermal damage can hold the ureter in the form, but there comes fluid outside. But if you have a leakage inside, a real defect, then the fluid comes strong outside. A small defect, we call it partial defect. It can be covered really exact one time with a stent, and all will be good after 6 to 8 weeks. After that time, the ureter will be heal itself, and we have a scale of 92%. That the wound healing is wonderful, and you doesn't need any treatment later. Then the second part is a complete defect. It's a complete defect of the ureter, means there's cutted or have a thermal damage, and in these cases we use also Allium stents. And If you put it inside, see the form of the Allium stent, it will show an X-ray in that part. The ends of the ureter will be smaller, and in the midline, where is the defect, there's a the fully range of Allium stent, and then you can measure it later also. The interesting part is why Allium is working at defects. It's really simple. We have only an inflow to 100%, and with the double J, we have only 10 to 30% inflow, but 70 to 90% outflow. That's why is the reason why the wound healing is better at Allium. And the second part is we have a bigger volume. So the bigger volume means if it's healed, later no stenosis can be developed. That means we use also in our hospital before memocut or metal resonance stents, and then we change totally to Allium because we have no benefit of the memocut or metal resonance stent against the Allium. Allium is better because it is simple to insert with Serlinger technique, and the only thing is what the other has nothing is that they are fully covered and the wound healing can be. This is not possible with memocut. And the difference to the another stent on market, Uenta, is that the stent can be unraveled if you pull it out. But Uenta, for example, in growth, that was a problem of all stents before also. What was developed, they comes inside of the tissue, and then if you want to replace the stent from the ureter, it destroys the ureter itself, so it has no benefit. The Allium is better. We have two kinds of Allium stents, one with the anchor, one without. I love the anchor without an anchor because I can use it from both sides, really simple, but the anchor is good if you use it in a lower part. The anchor has one radio marker on it, and the normal stent without any anchor has every time on the ends free radio marker. It is simple to see and also simple to check. You can use the parts without an anchor really simple, undergrad and retrograd, but if you use it also for retrograd with anchor, it's recommended to use the anchor from the other side. Interesting part is that if you make a good X-ray, you can see it exact the parts, the difference, how long it is also for measuring if you have a defect. Two ranges or two rings is 12 millimeter. One ring is 6 millimeters. So you can measure it later if you have a defect. We will see it now. This is a typical urology case, prostate cancer, laparoscopic treatment, radiotherapy, and what he had is now after salvage and so on. They had developed here a fistula and a stenosis. And this was in that case here. So he get a stent, and he doesn't love the stent because he had this feeling on it, and he had also a fistula on it. So what we do is now we put in this part the stent inside, the Allium stent, and you see it with guide wire. It's simple to in place. The fully part is covered. You see from here to here also stenosis. Here is it white. It's a typical part of radiotherapy in the pelvis, whereas a 45 gray on it. So there is a damaged part also, and that part of the fistula here was fully closed in the same moment. All it's okay. If you have cases like this one, like that lady here, with she is 71 years old with a rectum carcinoma and radiotherapy, and our surgery do the treatment, they did destroy totally the ureter. And what you see here, we bring the stent inside, cover the leakage, we bridge it, and we have no other treatments more because now it's bridged, the urine comes inside it without flu outside. But interesting is it, if you see that X-ray, you see here that from here to here, it's the fully weight of the stent, like in the animation on that side. That means from here to here, there is a destroyed part, and the destroyed part was covered and all it's okay. If you use the short stent only to cover only one problem, like here, fistula, then you put also for security a stent inside. We called it stent and stent technique, cheap stent inside and the good stent for the main problem, and all it's okay. You leave the good stent, the Allium, for 3 to 5 years, and you can change also every time the double J if you like it. What is called bridging realistically. Here you see the case, a realistic part of bridging. This is now cutted a ureter after corpectomy, after hysterectomy in a big oncology case. And the typically gynae mistake is that 4 centimeters from the ostium near to the artery uterine, they cut it with a thermal damage. We go now with the scope inside. You see here the border, that's the border of the cutted ureter, and now we go in that heel here inside. This is in here now, and what we want to do now to find the way to the other part of the ureter. We have 2 chances. In 80% of all cases, we can do it straightforward to find the way and go with the guide wire inside. In 20%, we need a rendezvous part to use the stent to come from the kidney after PNL and goes inside and finds the guide wire. If we catch the guide wire, what you see it now, we put a stent inside. We prefer for these cases the 200 millimeter stent. The 120 has 1 centimeter wide and the 200 has 9 millimeter wide. The good is, you see it now, we put a 200 millimeter stent inside. It's cover the part of it destroying. And at the end, what we find it, there was a scar. It looks like here a little smaller. After 1 week, it will be also bigger. It looks straightforward, all it's okay, but the stent is waterproof and no fluid goes out and all it's okay and all it's good. The same in that case. Typically case, hysterectomy, the ureter is cut at this area here. This is the bladder, this is a big urinoma. You will see it then in ultrasound really carefully. This is a urinoma here, and you see the white spots at the end. Here is the end of the ureter from the bladder, and the other part comes, look here now, from this side. This is the ureter from the other side. This was cut with the ultracision, and what we do is now, we go now inside, we check before, it is urine, it's not hematoma. We go from lower part, and with lower part, I don't find the way with the guide wire. I go straight inside of the urinoma, so I decide to make a rendezvous. Rendezvous means that I comes from up. You see a lot of people here. This is the time of Corona. Before, what we do now here on webinar, we do it in our hospital, and I invite colleagues to show it like we do it now. What we do now, we go with the guide wire through from the up part, catch the guide wire and goes with the rendezvous inside and bring the Allium stent in. You see the ends of the Allium stent here, where it is where the ends of the ureter make a little impression, and then we wait for 2 months. After the second day, you see the distance of 3 centimeters comes near to 1 centimeters or 11 millimeters. And after 2 months, we will check it. After 2 months, we bring it then out, and this is a day. We take the Allium stent out. You see it, it's no leakage more, no extravasation, and in ultrasound, you can check it really exact. This is the ureter, and this was the part where it was cut, 3 centimeters from here to there. And now, no stenosis, all comes together. You can check it also with elastography, with power mode, all looks very well. And with the scope, you can go inside it. You see only the area, in that area where was the stenosis, where was a break, there are some small polyps, but all it's okay and all it's okay. What you see now is an interesting case. It's a ureter arteric fistula. And in these cases, normally you need to open the lady or the patient, or to make a stent from the other side, but not its covering totally. So what we do it now, we'll go with a guide wire inside. It was really bloody all. and then I put the Allium stent inside. And in the same moment, if I put the Allium stent inside, the damaged part is it's covered, and no bleeding comes more. We have no hematuria. All looks nice then, and all it's very well. For more security, we decided now in the last 3 years that for the other side, from the vessel side, we make a deal with our radiologists and vessel surgeons that we do also a stent from the vessel side on it. So it is covered two sides, the problem from the vessel side, from the vessel surgeon or radiologist, and we do it from urology side, from the ureter. So all that's okay, and you doesn't need any treatment more. We leave that stent then for 3 to 5 years, then we can change it, because this is the part, that's why I recommend it. If you use it only from one side, from the vessel side, then the leakage from the ureter, it's not closed. So urine goes to the vessel stent, and then it will be an infection, and later you need to open it. So it is recommended now to do from both sides, all it's okay, and then we have no problems more. Interesting case, rectum carcinoma, they do a fully exenteration on the posterior side. And what they do now, after radiotherapy and exenteration, they damage the ureter. And they find it out with a vacuum pump. Why? It is not closed here. So they have urine inside. What they done is, they cut totally the ureter. And in these cases, if they cut it, then the ureter, it's open, and the urine goes then to the heel, and all it's problematic for everybody. What we do now, we go with the scope inside, you see the damaged ureter, it was fully cutted, it was inverted, and what we do is now, we put the Allium stent inside. This was a leakage area behind, this is 2 centimeters behind, this is the bladder, and this looks like where the anus was before, and here's a bone from the orthosacrum. This is the leakage part, and this goes here to the line. Area, and there comes the urine flowing. What we done is now, we put a stent inside to cover it, we bridge it, you will see it, and in the same moment, we put also a vacuum pump on it. And we put the high pressure with 40 millimeter water part, and so normally everybody think it must be not closed, but you see here the Allium stent close it, and the vacuum pump don't bring any urine through it. The stent closed and bridge every ureter, and all it's okay, you can wait. And after 1 week, 7 days later, we do it with a vessel, with a plastic surgeon, a plastic on it, and all it's okay. This is really good, because we have now reduced the hospitality time to shorter one. Before that, patients need to stay in a hospital for 3 to 4 months, and then they do after urology treatments, then the plastic. Now we can do it, and the patient leave at the end, the hospital, at the 21 day after the first treatment. You see it now, what and how the bridging is working. This is a hysterectomy, and after hysterectomy, what they do, they suture with the end suture of the vagina, the ureter. You see it here, totally necrosis at the end, and what they want to do is, they bring the uterus out. This is our ureter, and what they do it now, they catch it here with the suture. And then necrosis is coming, and after the 7th day, all its damage all comes here out through the vagina, and it was a big necrosis here. And you see it here now, big necrosis. The ureter was totally destroyed on that side. In X-ray, you will see it really exact. You see it now here. This is the ureter. On the other side, it comes also. That is faster one, because the ureter is a little obstructed nearby the cutting part. This is an area of necrosis, and behind is the vagina, and he looks at really straight. This is a part of the necrosis, and this is the vagina. What we do is now we examine it really exact with the X-ray before. We see it now really exact, nice to see, and now we show inside. With the scope, we have only the chance to go on the first 3.5 centimeters because behind the ureter is cutted. They do before a treatment with a nephrostoma on it and to want to go here. And what we do it now is we see it really exact. This is the ureter from here to here. There is the cutting point. And what you see it also, if you measure it, it's how I say it, 3.5 centimeters. The necrosis part is over on top, more than 2.6 centimeter, where we bridge it later. So we needed to examine also why it is. You see here the white spots. These are the sutures. So that's 0 microsuture, and they cut the ureter, and all was damaged now. So what you see it, we go in that area. There is a part, and what you see it now, we find the way. This is a guide wire. It's a Terumo guide wire, and we are now with a scope inside of the vagina and see there's the end of the ureter. And what we want to do it now to bridge it. We want to bridge the 2.6 centimeter area. We go now inside. You see here also nice ureteral seal. She have it also. And what we do it now, we go with 2 scopes. One inside of the vagina, one inside of the bladder. And now we go with the guide wire inside and want to bring the Allium stent inside and to show you how bridging is working. We see it now simultaneously. This is the scope side. This is from the vagina side. This is a guide wire. And you see I go with the Allium in, comes from the damaged part to the other damaged part. This will be the bridging part in the future. This is 2.6 centimeters where we want to bridge it. Then we go inside, and now you see it carefully how we can place the Allium. We go now inside it, and you see here the black line. This is the line of marking, and then the yellow point is coming, and the yellow point is a part where you can stop, and then you bring the cover back, because then we want to place it really carefully. You see it now from the vagina side. I go with the cover back, and the yellow every time I see with my eyes, and I can see it also in X-ray. In the animation you see it, cystoscope in the vagina and the cystoscope in the bladder. And now I go with the back, and now it is opening. You see here the stent. The stent is opening, and if you pull the cover back, you see now the skeleton, and it's totally waterproof. This is bridging, and this is how you can replace also, for example, fistula. All looks nice. So you see it inside here, and it is all it's okay. This is what I say before. If you bring it inside, you see here, this is a part of bridging part. These are the ends where it's cutted, all it's okay. No fluid comes out. So wound healing can be over the time, and all looks okay. And we have no problem more for these patients. You see here in the animation, this is a part, and this is a bridging part, and all it's okay. In 94%, we can replace all fistulas. Really simple, only to put the Allium stent inside. Ureteral stenting is recommended at tumors and long strictures, and if you have long strictures, you do it also stent over stent. You have also the chance to cover the fully part of the ureter. And we have also the chance to cover and closing the fistula partially or with a bridging in benign cases, and 100% in radiotherapy or tumor cases, you leave the stent inside, it is closing, and all it's okay. Important for us are the tips and tricks, and to avoid the pitfalls. What we use is, first, if we go inside, then the company recommended to dilatate to 14 Shire. I prefer stents like this one, the typical one. We don't like the balloon stents. They are too expensive. We are a pure country, we are Germany, we have not so much money. That's why it is better to use typically stents like this one. Second one, we use guide wire, and what we prefer is a guide wire with a soft tip. You can use also Fultirumo. It's sometimes problematic because it's like glue, but what we recommended is to use a thick guide wire like 0.3.5. Not too big, because that is then not recommended. You use with a soft tip, and I prefer only with a soft tip at the end, and all it's okay. Secondary, what I prefer also to replace, I prefer to use a rigid instruments like rigid ureteral scope or compact cystoscope. You can go straight inside, capture it with the forceps and pull it out. Next is, if you have a dislocation after inserting, you have the chance also to bring it a little down. If you don't open the stent totally, that's why we start every time with a stent higher to place it. Then you have the chance before you bring it back to pull it at the right position. This is really important. And secondary, if you dilatate it good, you can replace with the tip of it also to replace it. That's why you can go then also with a cover sheet back to the tip, close it, and then you capture the tip and bring it through, and all it's okay. Next question is incrustation. We find also incrustation, this is what I say also before, but it is really less than 1 to 2% only, but then also in long time stents, like in 3 years, for example. But it is no problem, because the stent has no only incrustation inside it and not outside it. And the stent is not fixed to the ureter. So you bring then the stent totally out. You capture it, bring it out, all it's okay. So it looks like then also the ureter like without any stone very well, because if you have a problem, it's inside of the stent, not outside. The only problem what you can have is then the ends of the stent can make a more tissue. In that case, we prefer also to use stent in stent, or to use stent over stent to fully cover. This is the reason why we said don't go with the tip too much high to the kidney. That was double stenting in one kidney. You see it, the stent looks very well. Only that was the part to the kidney. This was the part to the bladder. It looks a little inside of bladder, a little to the kidney. Only small part, no problem. And please don't use a laser to destroy stent. Somebody do it also, goes inside, because a laser destroys the stent. Very nice, but he destroy also the cover sheet. And then you fix cover sheet particles inside of the ureter. It is not recommended. Take it, pull it out, all it's okay. And these are the recommendations. And what I said before, it is not good to use stent by stent. You have to use it stent over stent. That was not big, deep enough inside. You need a covering area of 2 centimeters over. The points must be behind and not stent by stent. Then you have a dislocation and a hydronephrosis. This is a mistake, and you waste money and you waste time. This are my ideas and what we do now here in the charity every day. 2 of these cases, what you see also today, a bridging case in the same way we do today, and also another case of only normally standing over a long time stand and stand. This is simple to do and really easily. And I'm today also very fast, and our ideas also for the future to understand some things better, that we want to show you also in the time of Corona as a webinar, real treatment in the theater. And this is good. We have the chance now to do it with the Zoom and with Allium. They help us. We go in the theater and show you step by step, one case exact, only the tips and tricks what you need with your hand holding. And this is really recommended. then for everybody to see it. And this is what we want to do. And our question is also to the audience, what is your ideas? If you think it as a nice idea to make a divide to show something about urethra problems, then about stricture problems and so on, and let us hear. I open also the chat and see it. What are you feel about it? Doran, I give you back to you to promote the session.
Yeah, thank you very much, Dr. Neymeyer. It's very interesting as usual. Let's give to the audience to ask questions about the presentation, or if they have any question about the procedure, about the steps, about the indication, you can use the chat box. Okay, so the first question is, why do you put DJ inside the Allium stent?
Okay, if you start in 2011, we had a problem that the stent was too short, because sometimes it is cover our problem, but at the end it will be a little obstruction. So for the first 2 weeks, we put a DJ stent inside because it's simple and easy, and then we have no problems with the obstruction. It comes back. We have no edema there. After 2 weeks, we put the stent inside out, and so the Allium stent is covered that area very carefully. Now we do in special cases, because we know it, then more stent by stent to cover the full length of the kidney to the bladder, really exact. Okay, a case which was placed inside of the pular junction a little high, and it did not work correctly. Yes, good question, good question. What I say, if you have the kidney, you can go only 1 centimeter inside. If you have the kidney and you go totally inside, then it goes at the end of the kidney, and then you get also hydronephrosis, because you have to replace it only one side in. If you are too deep, then you are inside of the kidney, and it works also not. The problem is that you make a good position, and the good position is 1 or 1.5 centimeter above the pular junction part. Because if you make it in the theater, it looks very well. But you see, that's why I show you the jumping kidney. If the patient is jumping and it's moving, then the ureter is also moving, and you can make a dislocation a little. So you need a covering part of 1.5 to 1 centimeters above the pular junction area.
Yeah, but yeah, they ask about how do you make a reposition by lowering the stent. How do you take down the stent? If it's a
I go inside. This is a trick. I use a balloon from our vessel surgeon to bring also the tromps out. I go with the scope inside, because sometimes you have a problem. The stent is so high, you have no chance to go with the rigid and to take it with the grasper. I go then with a small balloon inside, take the balloon, and it's pressing against the stent, and I can replace it a little, and then all it's okay. This is a trick what I want to show you next time also. We have some videos on it. That's why I say we need tips and tricks for every diseases, because every disease had a lot of more tricks what I show you now here. Also, the good question was, you use Allium in bigger bladder? Yes, we use it a lot of times, but if you use it in bigger bladder, in our hospital, I preferred also Wallace anastomosis. That means 2 ureter left by left. If you put only a stent in one side, this is a good area then, and the Allium pressing the other, and so you have the hydronephrotic on the other side. In bigger bladder, you need 2 stents on left side and right side, and you have like a kissing of the stent there, so you have no problem. But this is important. Also in new bladder, the same way. new bladder you can do it also, but he has a problem to bring the stent inside. In new bladder, I bring it right inside. We can show you also videos. And at new bladder, it is then the problem, where is the ureter to the new bladder? Because everybody has his own technique. I prefer 2 ears, left and right side the ureter. Sometimes use the Indiana pouch, some use only at 1 ear, both. So for every kind, we have some samples and we can show it to you. Okay, thanks. Next question.
Yeah, I don't see any more questions. So, okay, someone is writing.
Okay, Thomas, right. If the case is not related to fistula.
Okay.
Okay.
Guys, you can just unmute yourself and ask the question.
Yes, unmute it.
Yeah. Do you remove the stent before 3 years by default?
Yes. I say only you have a chance now to stay the stent inside for 3 years if you need it. In fistula cases, we know now that it is enough to leave it inside for 2 to 3 months. After that time, all is closed. Then we bring it out. In case of strictures, we have it for longer time. Also in cases, if they had a stone building patient and some radiotherapy parts on ureter, then we leave it inside. In case of the disease, you can decide. The good thing is we have now a stent that is waterproof. Now use it for the full length of the ureter, and you have a lot of time to leave it inside.
I would like to ask you, Dr. Neymeyer, what is the recommendation for follow-up for stricture for long time, for 2-3 years? How often do you make the follow-up, and what is included?
Okay, stricture is one part for the next webinar also. The problems of the stricture is we change the technique a lot of times because it is not only recommended what we do like every years before to dilate the stricture. If you dilate the stricture and you put the stent inside, it looks very well. If you put the stent later out, the stricture comes again. That's why you have a problem. Make a long-term stent or make an open treatment or plastic treatment of the ureter. What we do now is we use it like tissue engineering. We cut totally the stricture, put the Allium stent inside, and we generate a new part of ureter. And so we have now also a new treatment to replace the strictures very carefully and totally.
Okay, what about the how to?
Yes, and also here from Theo. Okay, you can bridge the technique also in open surgery. Yes, we can do it. And also in laparoscopic treatments, we can use it also. It's no problem. We done it.
Okay, can you explain the audience about the removal of the stent? How to remove the stent?
The stent removal is really simple. You go inside with a grasper, and you have 3 edges. You have now 3 edges of the stent. And one of these you capture with the grasper and you pull it. And normally you can bring the stent totally out, totally with one part. It's no problem. But in some cases, the first 2 or 3 rings will be destroyed, unravel it itself, and then comes the stent totally out. You have the chance to bring the stent really exact out only with a grasper at the end of the cystoscope or of the ureteranoscope, and you pull it out and there's no problem, and you have also no problem later.
From your experience, did you find any difficulties with removal of the Allium stents?
No, not yet. We have some cases. We have one case where we have a problem. That was not a problem of the Allium stent. It was a problem of the patient itself. It was radiotherapy patient after a lot of other diseases, and then we bring the stent out at the end, and that was nice for us also to see at the end, because it was also the arterial uterine fistula, that the stent is covering the fully part of destroyed for a long time, and we have some cases of it because we use treatment for Allium for that kind of fistulas, but we do also with the vessel surgeons treatments later, and I can show you now then also how it looks like inside it, how the Allium is working, but this is a special part of webinar for next time.
Dr. Neymeyer,
Yes.
antibiotics.
Wait.
A to można przekręcić, panie komentarze, nie? No.
Can you explain, please, about antibiotics before or after? What is your recommendation?
Only single shot. We give
To są konsultacje telefoniczne.
we give only single shot, and in chronic infection we have no chance to replace it. We do it typically one every urologist.
Wszyscy mają konsultacje telefoniczne. Nie, no to...
Hello?
Yes,
Yeah,
yes, we hear
now
you.
you can, please.
Okay, sorry, I don't hear it so much because the microphone was not so nice. As a recommendation, what we write now is for everybody, also recommendation for antibiotics. It is a long discussion also. We never seen any infections on the stents. Also, if the stent goes through abscess, for example. So we use typically antibiotics, what you will find in an antibiogram before, not other things. If you doesn't have any antibiotics before, we use only one single shot.
And during the after deployment of the stent, do you use the antibiotic for 5 or 10 days after deployment?
No,
Not at all.
no, only if you need it. Otherwise, no antibiotics.
Okay, in case there is infection with the patient after insertion, let's say after 1 month, 6 months, I don't know. In case of infection, what is the recommendation?
We use a single shot antibiotic every day. For example, nitrofurantoin, for example, 100 milligram, but then for 6 months. And also here is a good question here, also stone development. You give the same recommendation at stone developing like you do it at normal double J also. We put the stent inside, and if he has a stone building patient, he have to check it with a pH test stick itself, and then we go typically urology drugs to bring the acid or the base higher. So it is a typically normal recommendation, not special things.
Thank you very much.
There is a question, someone asked how to judge the best time to remove Allium stents in the function is okay.
Thomas, Thomas asked here, for which other procedures except we would like recommend to use Allium stent for prior in combination with other departments treatment. Yes, we have now, we work now for the last 9 years. Yes, since we started in 2011. It's now 9 to 10 years. Now we work with all departments of our hospital together. We can show you problems from the orthopedics or surgeries. They're destroyed. Also the wounds. We use Allium stents. They know it, that we can cover it totally and replace that problems. Also with neurosurgery, also with the vessel surgery, with the gynae department and with the surgery. And so we have friendly relationship with this. We know and they know what they can use it also during open treatment. That was a good question. If we have problems or if our surgeon in the surgery after rectum carcinoma, they cut totally the ureter and haven't any chance to bridge something or make some interponent on it, we make it also opening part to bring an Allium stent inside, leave it, and all it's okay. So we have good relations, and believe only things what you see, we show it next time, if you like it.
I like it.
Okay, just we want to share with you a quick test about the presentation.
So I would like to say something before we just start to do that. As Dr. Neymeyer said, we are using this situation. Maybe we should have done that before, to do webinars and training over the line, online. The idea is that today you saw an introduction of the range of procedure that the Allium stent can be used. And then what we want to do is to have a session for one or for two specific procedures and to go in depth, meaning either we will do a live from the theater, a live case, or we will show the full scale of the patient before, after, during the procedure, show the movie of the procedure itself. Sometimes it's even better for training not to have a live case, but to have a movie that you can stop and wait for 2 minutes and explain what is happening, and something that you cannot do in a live surgery. We will send you a list of the webinars that we plan to do. We will welcome any ideas coming from you of something that you want to get a training on. And more than that, we will be more than happy to get some materials from you about procedures that you did, from the training that you got or from other training that you got and that you want to share with the audience. We will get them, review them, and then let you present it in a forum like that for all the users. For each one of the session, we plan to have a small test, and at the end, we want to have a certificate saying that you passed 1, 2, 3, 4. We will record everything. You passed 1, 2, 3, 4 sessions, and you are certified to do these following procedures. Any ideas will be welcome. Yes, Dr. Neymeyer, please.
Yes. Can I?
Yeah, we can hear.
I read here a lot of good questions, and the same questions last time also. We can speak a lot of transplant. We have a lot of transplant patients. We use Allium stent. We also we can show something about some questions how the long-term results after bridging, also detect, exchange when we can change it. All questions what we see here on the chat room we can answer. And the best of all questions, but it must be also from Israel, I think so, Dr. Jesus Grozen, can you clean the stent inside? Yes, I think then I'd take a brush from my wife and push it. No, you can't clean it inside. But it's a good idea to do it. But the question is really nice. And I show you a trick, a little to clean, not with a brush, with the other things. This is why we talk here together. We want to show tips and tricks, and our 10 years of techniques and what we developed, we want to show and we want to bring it and discuss it with you also, that we bring it better for the patient. That was our idea, and that was we want to find, or we find make a foundation of the CMOOC committee, and if you like it, work with us and together, and the university give us also the CE points. Our doctors' chamber get us CE points for every webinar. Okay, thanks.
Thank you very much, Dr. Neymeyer. Hope to see you again in the next webinar that will be in the last week of April. We will send you the email for the topics. It will be in 2 weeks.
On the 23rd.
23rd.
Yeah. The 23rd on the same hour.
Okay, we will send you separately the email with the invitation. And now, if I will put the test, it's very short, and also you can use the link to connect the test and then send us back the results.
Doron, did you send the link?
Yeah, it's in the chat box.
Okay, so in the chat box, you have the link for the webinar, for the test, sorry. So you can go inside and do it with us, or to do it later. We will go over it now. So let's start, and please answer. You can answer in the chat where the answer is 1, 2, 3, 4. Just answer the number on the chat, and we'll do it. This one we will do together. Please, Doron.
So, what is the approval and dwelling time for Allium stents?
Yes, 3 years.
Right.
Next.
Yeah.
No, you can take it down a bit. The question is a bit down.
Yeah. Allium stent are uncover, partially cover, fully cover, or semi-cover? Yeah, it's fully covered. Okay, the stent with an anchor. The URS stent with anchor should be in the stricture located upper ureter, lower ureter, prostate urethra, or bulbar urethra. So the URS with anchor only in the lower ureter.
Give people a chance to answer, you know, give a couple of seconds just to write a correct answer.
The polymer coating, okay, what is the purpose of the polymer? Reduce migration, fixate the stent, prevent ingrowth, reduce rates of classification and stone formation, and provides better resistance to the tissue. So the answer is prevent ingrowth, reduce rates of classification and stone formation. How many markers on the stent? 2, 4, 6, or 7, or 8? Okay, so the answer here is 6 on 7. If it's anchor stent, you have 7. And if it's without, we have 6, 3 markers both in each side. URS delivery system is 10 French, and dilation should be DLIF 2, 10, 12, 11, or 14.
This one everybody knows. Not 10. Yes.
Okay, so the answer is 14. Okay, if you use rigid dilators, it's up to 14 French. And if you use balloon, it's 15, so the minimum it should be 14 French. Okay, which semi-stiff guide-wise recommend to use with Allium URS? 25, 38, 0035, or all of the above?
This is also consensus about it, everybody knows.
Right, it's 0035 inch. When removing Allium stent, it will always unravel. The stent should not be removed. It's a permanent implant. Most of the time slide out and sometimes unravel a bit and then slide out. The stent cannot remove.
Okay, Doron, you should explain people why it's not answer number 2.
Yeah, so the stent is, of course,
because many answered number 2. It's not correct answer. Yes,
it's not a permanent implant. Okay, the stent most of the time slide out in one piece, and the unraveling mechanism, which is just a backup. In case of high resistance, the 2, 3, 4 lines of the beginning of the stent will start to unravel, and then the stent will slide out. After deployment of each stent, physician should add saline through delivery system, push delivery system deeper into the body, immediately remove the delivery system, wait 3 minutes, and then carefully pull the delivery stent out.
yes, wait is correct.
You must wait 3 minutes and then carefully pull the delivery system down. The reason to wait after deployment is to reduce the stress on the ureter, to allow the X-ray shot, to allow a stent radial force to work and increase the lumen, to check the stricture with construct material.
Doron, please explain to the audience why it's not answer number 2.
This one?
Yes, because many wrote number 2.
Okay. The radial force of the stent is work from the inside of the stent to outside. Okay, so that's why we need to wait, because we need to give the stent to expand and push the stricture out from the inner side to outside. So this is the answer. Which one of the following is not indication for URS? Benign stricture, malignant stricture, BPH, stricture after radiotherapy. Right. This is not indication. Okay, here you just need to fill your email, address, country, and occupation. If you are a urologist or a nurse or distributor, and then see the result and send us it for the certification. So again, thank you very much, all of you. It was nice to see you again.